Dr. Sunil Roy, working as a consultant interventional cardiologist at Astamed City, Kochi. So I am presenting here in the heart failure meeting today on when and how to evaluate CAD in patients with heart failure. So coronary artery disease represents the major cause of heart failure. Because of the improvement in the treatment of acute coronary syndromes, many of the patients present with heart failure. So the recognition of CAD in patients presenting with heart failure has its own prognostic significance. And other aspect is the treatment of coronary artery disease may improve the prognosis in these patients with CAD in heart failure. So when and how to evaluate these patients? So I will say we should evaluate in all patients with physical examination, history, physical examination, ECG, echocardiogram, and other necessary investigations. And if we don't have CAD in the basic physical examination, still we have to evaluate for CAD because ACC/AHA guideline recommend class 2 recommendation for evaluation of CAD in patients with heart failure, presenting with heart failure. So functional imaging and anatomical imaging both needs to be done. And the main aspect of this one is recognition of the hibernating myocardial viability, myocardial viability. So we can have echocardiogram. Echocardiogram, it's a routine, easily available investigation which give information regarding the viability. Then SPECT scan and PET scan, cardiac MRI, and these are the investigation which help to give the idea regarding the viability. And about the coronary artery disease, coronary calcium scoring, coronary CT angiography, and invasive coronary angiography as and when required. So what is the role of revascularization in patients with the CAD and heart failure? The ESC recommendation says all patients with LV ejection fraction less than 35% and significant coronary artery disease should undergo revascularization. But this recommendation comes from the meta-analysis, earlier studies, observational studies and meta-analysis. But the randomized double-blind control trial that doesn't support this one except stitch trial. So there are heart trial, then PPR trial, stitch trial, and the other trials. Only the stitch trial gave the recommendation, and that too on a long-term follow-up of 10 years. At 5-year follow-up, the all-cause mortality was same in both the groups. But on extended follow-up, there was a significant difference in the all-cause mortality in patients treated with coronary artery bypass surgery compared to medical therapy. And the other randomized double-blind control trial of PCA in patients with ischemic cardiomyopathy doesn't support the use of PCA over medical therapy. So all patients with ischemic cardiomyopathy, if they are offering revascularization, the best method will be coronary artery bypass surgery. And routine viability testing does not add value to the revascularization decision. But in patients who are having other comorbid condition where the surgical risk is high, selective use of myocardial imaging test will be useful to decide which patient should undergo revascularization and which patient we can continue on medical treatment.